Hi, guys. Welcome back to another episode of Personal Trainers Who Care. I'm actually here today with Dr. Rebecca Chase. So she's a women's health doc at Novel Health and Lifespan. And she specializes, she helps with women in general. But the reason why I wanted to have her on today was because she works with a lot of menopausal women. And it's a big portion of our clientele here at Freeform. And I really want to give you guys as much valuable information as possible in managing this portion of your life. And I love women, so yeah. So why don't you just take it away? Let me know all about what got you into this and the kind of work that you do at Novel Health and Lifespan specifically.
Oh my God. Okay. That's loaded.
I know.
All right. What got me into this? So I always knew I wanted to be a doctor. I actually applied 5 times.
No
We were just
way.
talking about this lately. Yeah. I was like, I can't really see myself doing anything else. But first few years of university, I was kind of had like lower-ish grades. And so then by the time I finally got it up, I was like, okay, I need to do a couple more years of school. So I applied a bunch. And then once I was in medical school, I really liked OB. I was like, I think that's what I'd want to do. Like, I love the idea of pregnancy. I love how a woman's body can change like over time to accommodate this new life. Like, that is wild. Okay. And then when I started doing my rotations through med school, I was like, ew, birth is literally the most disgusting thing in the entire world. Like, I love the before, I love the after, but like one clitoral tear and I'm like, I was out. Like, that's the last. I cannot see it. I was so happy when I had my own babies. I was like, they can't force me to look. Like, they can't. They literally can't. They can't. Anyway, so I always had a passion for gynae, but then that surgical or that like baby catching, that kind of went out the window. So
Right. So you were doing that and you were like, I can't.
yeah,
deal with this.
we have to do, it's a mandatory rotation like in medical school, just
Yeah.
like surgery is, just like internal medicine. And I really liked internal medicine more than I did any kind of surgery, including like, like obstetrics or gynecology.
Sorry, what is internal medicine?
Internal medicine is kind of like, Dr. House. Okay. So it's like family medicine, but much more complex.
Yeah.
Okay. So this is like hospitalist medicine.
Okay.
All right. So I was like, okay, no, I really like that a lot more. So family medicine was definitely way more my style. And then I was practicing in comprehensive family medicine for a couple of years, but I was always coming back to like these women health things. And actually my friend Lydia, who I tell this story all the time, and she would tell you too, and this is not, I have permission to share this, but her doctor was at the location that I was doing a family med locum at. And she was like, I really need my IUD replaced. Like, can you please do it? And I was like, no, I really don't want to. I haven't done one since residency. And she was like, just do it. Like, who cares? Like, just who cares? She's also a doctor. Okay. And so she's like,
okay.
just do it. Just do it. Anyways. And so I just did it and it went super well. And that experience gave me the confidence to just like keep doing them. And then I became like the IUD girl at Ottawa U. And then I got a focus practice in like gynecology and obstetrics, which is when you apply and based on your billings and how many women that you see or how many people you see that fit that diagnostic code, you can be given this. And so that is basically you're providing subspecialist care in the community. So instead of having to instead of having to refer to an obstetrician's gynecologist who have like a specialty who are mostly doing surgeries, people can refer to me in the community because I do have that extra kind of little expertise and not get dinged. That will go away. Like if you're a family doctor, you go to another family doctor. Your family doctor, if it's a capitation model, they have to pay that doctor. Anyways, it's so stupid, but whatever, that will be going away to help barriers for access. But still, like we're still recognized as people who can bill certain codes.
Okay.
Yeah.
So the bulk of the work that you do now is mostly menopause stuff?
So so I do everything. So I do menopause. I do like polycystic ovarian syndrome is another really big area of interest.
100%.
I love contraception. I love reversible but implantable contraception. So like the IUD, I don't love the next one. That's a whole other episode. But anyways, I like that women have options. I like to be the person to give them these options.
Next one on, is that the patch?
That's the rod.
Oh, the rod. Okay.
Evra's the patch. Mm-hmm.
Okay.
Yeah. And so but because there's so few people doing menopause, that's kind of taken over my practice and I love it. I love it.
There's so few people doing menopause in Ottawa or in general?
In general.
Okay.
In general.
I mean, I guess like you sort of hear about how underfunded and how like how people are just not aware of what's
Oh
going
my
on with
God,
women
no.
and the understudied women's health is. But there's just not enough people going into it. There's not enough staff.
No,
What's
people
the
have,
issue?
okay, so there's, as always, one problem has multiple,
That's it for sure. Yeah.
multiple things feeding it. So
Yeah.
one, no, we have doctors. We definitely have doctors. To be able to gain all the knowledge in this and then to bill the government for a consult, it's not very, like, it doesn't pay very well. Like, it would be a lot more, it's a lot more costly to the government, or a lot more, like, it pays doctors a lot better to insert an IUD, for example, for the same amount of time or even less. All right. So
Right. So it's not as profitable
not as
for the
profitable.
government and for doctors to go into women's
Or
health.
for doctors mostly. Okay. So when the people who are doing it, like, one, it's like the family doctors, okay, who are doing it because they see a large array of people and, like, this is something they know their patients super well. Like, they can start them on that. That is very, like, that is the way it should be, okay? But
Yeah.
that's not, because people don't feel comfortable prescribing hormones, or really even perimenopause right now. People don't feel comfortable treating perimenopause. So it gets referred to us, okay? Or somebody else who provides subspecialist care.
Us meaning
Like, yeah, family doctor, or like women's health
women's
kind of
health doctors.
specialist. So
Okay.
whether
Okay.
it be family doctors with this kind of focused practice, or if it's like obstetrics or gynecologists in the community. And so yeah, so when someone hears a whisper that, like, someone is doing menopause care, like, our wait lists fill up super, super quickly. Okay. And so, yeah, it's wild. And the reason is, and when I talk to, like, my colleagues, they're like, oh my God, when women bring up menopause, I'm just like, no, 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 no. Like, please don't.
Because they don't know how to deal with it.
Because no, even if they do, they're like, we're going to get into so many things, because you can't touch on one issue. And this is so far reaching, like menopause and the
Yes.
effects. Yeah. And so the effects that it has on your life are so far reaching. And then you're going to get into that. You're going to get into libido. You're going to get into your relationship. You're going to get into, and if you're somebody who, like, needs to see a lot of patients, like, these are cases that take a lot longer. So yeah.
So you guys are
that's
trying
one.
to fill the gap there and try to
But
open up the space for people to talk more is your goal?
well, that's always a goal for every
For sure,
appointment.
yeah.
Okay. But ideally, my personal goal, is to get more family doctors comfortable treating patients when they first come to them. Because one, if a patient has to wait till July to see me, which is like when I'm booking now, it's December 2025. You might see me in July 2026.
That is insane.
In that time, like, a lot could go a lot worse, right? And so
No, it's so true. Yeah.
and so we talked, that's one of the things. So it's not very profitable. And I don't want you to walk away from this being like, doctors make too much money.
Well,
No,
they gotta make money, but
family doctors make shit. They make shit money.
I
Okay.
know.
So if there's any, and then, yeah. And so, yeah, if there's any, like, opportunity to be fairly paid for your work, or if something really does not pay you fairly for your work, that would be what I would put menopause into.
they are so overworked and it's such a
Overwork and
nightmare.
underpaid. And when people talk shit about their doctor, I'm like, you know what? Even if they, like, I don't know, there's obviously some situations I'm like, whoa, okay, that sounds bad. But, like, if there was, like, oh, they don't seem to be very, like, compassionate. I'm like, yeah, I get it. It's, like, such a tough job. And that's why I don't
For
do
sure.
comprehensive
Yeah.
family medicine anymore. So
Yeah.
I stan a family doctor. And now I'm asking them to do one more thing, which I understand is, like, not always possible. But the reason they're scared of prescribing hormones is because of a study that was done in 2002 called the Women's Health Initiative. And so they gave women who were, so even some who were in menopause for over 30 years, to see if giving them these hormonal therapy, how it would affect, like, their cardiovascular risks. Okay. There was different preparations of estrogen, different preparations of progestins, and a lot of the women, like, had strokes. There was, like, lots of breast cancer, so much that they had to end the study early. And so that huge scare led to lots of family doctors deprescribing women who had been on hormones for years, and who it was really controlling, like hot flashes, mood swings, metabolic disorders, like, presented themselves afterwards, and just generally, like, wreaked havoc on their lives.
Right.
Okay. And so even young doctors, even though this was in 2002, we would have been like, like 10 when this came out. 10, I would have been 15, but you still knew that hormones were, or you still remember hearing whispers that hormones were not good. And so then it's taken a long time to go back there. And when there's a big gap between what medicine is willing to tackle and a problem that exists, that lays the groundwork for like wellness influencers to kind of infiltrate. Mm-hmm. Yeah. And like, that's where it gets a bit sticky, you know? So some people will come in and see me and be like, you know, I've seen this functional practitioner for a long time, so naturopath, and some are like incredible, don't get me wrong. But they're like, okay, and they had put me on a bunch of these supplements that cost me like over $700 and I don't feel any better. And I'm like, yeah. So anyways, my goal is to hopefully give family doctors like a really easy way to identify perimenopause and menopause, and then when to treat, right? And to feel confident in treating, and to know that like these are quite safe, but like everything, it's risk benefit. And once a week, I will write in a chart a quote that one of my patients will say, and it'll be like, I don't care what this does. I just need these hot flashes to end, or I just need vaginal dryness to end.
So it's like the desperation of the symptoms from menopause is so strong that these women literally do not care if there is, you know, a risk of developing.
They don't give a shit. Give a shit.
Yeah.
Okay.
Yeah.
They just want to be informed and they want the choice. Right. And
which is the most important part. 100%.
Right?
Yeah.
Right. These women are just a little bit older than us. Like I often see people who are like, you know, in their early 40s starting to have really, really bad hot flashes that are affecting their work. And so, interesting fact, 10% of women will actually take themselves out of the workforce or like decline a promotion or not go for a promotion because of their menopausal symptoms or their perimenopausal symptoms.
Because they know that they can't keep up with it, or
exactly.
they feel that they can't.
It was a lot of brain fog, fatigue. Okay. And so, yeah, they can't function. They can't multitask the way they used to. They can't remember numbers from one Excel sheet to another. That's something I hear a lot. And so they take themselves out of the game. And 10%, like that's a huge chunk of the workforce.
Mm-hmm.
Right.
So that is so interesting. And how does chronic stress feed into the development of menopause and how severe that development can be? Like what?
Oh yeah. So for VMS, so vasomotor symptoms, there's often triggers. Okay. And so for a lot of people, that's spicy food. A lot of people, that is like not sleeping enough. Or stress. So if they're under a lot of work stress, okay, people will get, it's kind of like, I think of it as like a migraine, okay? They'll get a lot more hot flashes, okay? And then when they'll go down south or whatever for a week, they'll be like, I have nothing, you know, I'm feeling a lot better, okay? And so, yes, so absolutely, like high levels of stress can feed into that.
So it would be, you know, just a constant feedback loop.
I prefer the term shit cycle.
Shit cycle. There you go.
You just like, and then because of the stress, you kind of can't get out of it. And then it feeds into worse VMS. And then you're kind of more tired. And then you're more stressed. And then you're more underperforming. And then you're just stuck. You're stuck.
Yeah. Mm-hmm. What's the number one way that I'm sure it varies. I kind of hate questions like this, but.
Well, you answered your own question.
To disrupt the cycle, where do you usually try to nip it in the bud?
So exactly. So it depends on the patient. So if they come in and they're like, I have hot flashes every single night. Okay. And because they have hot flashes every single night, they're not sleeping. They're not sleeping. Okay. And then because they're not sleeping, they're tired during the day. They're not exercising. Okay. So they're not building that they're not getting those cardiometabolic advantages that they were before. Yep. They're not getting those cognitive benefits. They're not getting, the mood benefits. Yep. And then they just, again, another shit cycle. So if I can disrupt that cycle by giving them either, and sometimes we'll look in, what are you doing right before bed? Okay. Like, are you able to get to bed? But I mean, hot flashes are something that you can't really, control. That's your body like wild in. And so if they are in perimenopause, like, you know what, and they need contraception, like, you know what, a birth control pill might be a really, really good option for you. And there's some really new options that are much gentler than maybe the ones that you had been on in your teens that you're like, I'm not going back to that. Or maybe like, let's check a ferritin, let's look at your iron levels. Yeah. If your iron is like super, super low, or even if you don't have anemia, but your iron stores are low, that can worsen a lot of the symptoms or even mimic the symptoms of menopause. So
Okay.
yeah, so I do a full blood panel. And so that includes,
What are the markers you're looking at specifically?
so I always I take advantage of I really like metabolism. So I always look at like an HbA1c. If they're giving a strong history of like insulin resistance, and this is most people in perimenopause, or just most people, okay?
Yeah, most people in general.
But just most people,
It's not
okay?
just menopausal,
Okay,
yeah.
and based on like their family history, I always do a creatinine. I always do like a lipid profile. I'm always going to do a CBC. So that's checking for just their like it's a complete blood count is what that means. So we're checking for your hemoglobin, your MCV. So an indication, are you like, what are the cells of these? What are the size of these cells? Does it look like you might be more, if you are anemic, does that point us to more of a vitamin B deficiency, B12 deficiency, or like an iron deficiency? I'll also throw on a ferritin. I'll also throw on a B12 and a TSH, so a thyroid stimulating hormone. Okay, and then I always do a vitamin D level. And this is, so if you look at choosing wisely, that's not indicated to test on everybody, but a lot of people aren't on it because they don't think they need it. And so I will do a vitamin D level as like a convinsogram is what I call it.
100%.
And everyone is low.
Everyone.
And the lowest people are the people who don't take it in the summer because they think the sun is going to compensate.
They think it's enough.
We are too high up. We
Yeah.
are too high up. We are queens of the north.
Yeah, like 75% of people in the northern hemisphere are getting insufficient amounts, and then there's like, I don't know, it's like 60 or 50 that are getting they're deficient.
Yeah.
Right. So it's
Yeah.
like literally everyone.
Everyone's deficient.
Yeah.
Everyone's deficient. And
Yeah.
even some people who are supplementing, but they're only taking 1,000 and they're a little bit older. They're having symptoms of like they've had anemia most recently. I'm like, I'll throw it on anyways. And then often that comes back as, so I'm like, you really need to take more than you think. So now right off the bat, I say like 1,000 international units is not enough. 2,000 international units is where I start. By the way, this is not official medical advice. It's just, there might be some reasons that you can't take 2,000s, like especially if you're prone to kidney stones. But yeah, for most patients, that's not an issue.
Okay. And usually with that, people start to see improvement in other menopausal symptoms, or at least help with the fatigue. Like, how does that?
Okay. Oh my gosh. I'm very happy you asked this because let me tell you a great anecdote. So I had this one patient who was a waitress, and and when we went through my menopause questionnaire, like she had everything. She had sleep, she had mood, she had like vaginal dryness, she had everything. The biggest thing for her was joint pain. She's like, I have had to stop working. Okay. And we know that estrogen, there are estrogen receptors on the tendons as well as the muscles.
Yes.
And so when we take that away, there's a lot more pain and joint pain, muscle pain that women will report that kind of travels, or they might have one, joint that's particularly affected. Anyways, her was just full body pain. Anyway, so I had read her the Riot Act about, hormones. This is what I recommend. This is the risk. You're fairly low risk given this. And then I had said and then I had called her the next week to say, you need to take vitamin D because her level was super low.
Yeah.
Okay. When I had called her back in, 2-3 months is when I typically do my follow-ups to see like how the estrogen and the progesterone therapy had gone. She was like, you know what? Like, I actually didn't take it at all. The only thing I did was I took vitamin D, and she's like, all my pain is gone. Everything is gone.
Yeah.
And so that was so fun for me because I was like, wow, okay, you could have gotten much better in this 3 months. But I mean, I'm so happy. And so then she was actually able to pick up more shifts because this was really affecting
her work,
her money she was taking home. Right.
Yeah. 100%.
And so she was part of in her family, she really needed to bring that money home. And so the fact that she had to really take herself out of the game because of this joint pain. And it was as simple as a $10 over-the-counter vitamin supplementation.
Baseline.
It was amazing.
It needs to be in everyone's repertoire. It's so true. You said something that kind of triggered a thought process for me regarding the estrogen receptors in muscles and connective tissue and stuff like that. And from some of the stuff that I've read is that varying levels of estrogen can affect your tissue integrity. So connective tissue integrity. So you can be more at risk for connective tissue disorders with different levels of estrogen. How does that relate to women who are menopausal? Because it's like you have low estrogen. Do you have high estrogen relative to progesterone? Like
Oh, yes. I mean, so
what is that? Like what is
yeah.
going on there?
Yeah. So are you talking about estrogen dominant? This
Dominance,
whole
yep,
thing?
for
Yeah.
sure. And I think that there's like just so much confusion about are you estrogen dominant if it's much higher relative to progesterone, or what is like, even just for my curiosity, what is
Yeah.
going on there? Like,
Yeah. So this is something we don't really use it in the medical. Like I'll never be like, that person is estrogen dominant, you know?
yeah,
I will say their symptoms seem to be more due to a lack of progesterone. So that's what we'll start. Okay. Estrogen and comparing estrogen and progesterone is like apples and oranges.
yep,
Okay.
yep.
And then also if people are basing on their blood work and they're like, oh my God, my estrogen is huge, but my progesterone is low. I hate blood work for hormones. Okay. Unless like if you still have a uterus, if you're still cycling, your or even if not even if you still have a uterus or not, but like if you still have ovaries, you're still cycling, that those values are going to be different hour to hour.
Yeah,
Okay.
yeah.
It doesn't mean anything. The
It's
most
just a tiny little snapshot.
it
I
is
mean,
a
with the blood work.
snapshot.
Yeah.
It is a snapshot. It's impossible for me to get a video of what's going on, but the closest I have is your diary. Okay, so if you can show me a calendar and it says like, "Hey, the week before my period, I'm gonna burn this house down. Like, I'm having really really bad hot flashes. You know, that's when I'm really not sleeping. That's when I'm the most ragey. Then I'll be like, okay, then this to me tells a story of not enough progesterone, and let's supplement it."
Okay.
Yeah. And then on the contrary, if they're like, I am having a lot of hot flashes during the day, I have a dry vagina, I'm like, okay, we need more estrogen. And it's as simple as that. I don't need to get into tests. I don't need you to order a $400 Dutch test and like piss on it and like send it through the mail and then tell me, no,
Yes.
I don't need that. I don't
Yeah.
need that. I don't need you to do that either.
Yeah. I think that there's like a lot of predatory, people, especially these days, like the internet, there's like a million tests that you can do, a million health practitioners, a million supplements that everyone is saying that you should be taking. And I was just talking about this with my friends last night. But like going into 26, we're going minimal supplementation.
Oh,
like
I love that.
D3,
Okay, tell me all your
K2,
supplements. Oh, I like that. Okay.
vitamin C,
Like it.
magnesium complex.
Ooh.
That's it.
Cut. Okay, what about creatine?
I go on and off creatine.
Okay, yeah, I would
I
add
am such
that.
a busy person though, and when I'm like locked in on my program, it's great and I love it, but one day you fall off and then there's the whole train of like, the dehydration, and then I'm on my feet literally all day.
All day, yeah.
So have to drink that much water is a bit
Good.
harder for me, but yeah, I cycle through it. But I have noticed personally with the creatine that my cycles become more manageable. Less
Interesting.
cramping, sleep better in general. So I highly recommend it for everyone,
Yeah.
and I will always go back to it. It's always in my closet.
If I can make a recommendation, to switch to gummies. Like gummy creatines are amazing. And so I get this really great, I wish I knew the name of it, but it's from Trois Rivières. And so it's a Canadian supplement.
Yeah.
It's these gummies. And yeah, me and my husband, we take them every day and we never forget because they're delicious. They're absolutely delicious.
Okay.
And so then so women make about 60 to 70% endogenous creatine.
Yeah.
Like your kidneys will put off, and male kidneys will put off about a gram per day. So that's like not really that much. Okay.
Yeah.
You can of course train yourselves to be to be more, how do you say, to have like a lesser refractory period the more you train. Okay. But creatine is going to have that because of its effect on ATP. And so that is not just your muscles. That's not just performance.
Just pause. Explain what ATP is for a second and the importance of that.
Okay, so ATP is adenosine triphosphate. It's essentially like energy currency in the body.
Yeah.
And so once you use that energy, it becomes ADP. Okay. And so what it does is it gives another molecule of phosphate to re-become ATP. All right.
Okay.
So it shortens the refractory period. And so you can kind of get back to, your cells can be that much more
Replenish
functional.
quicker,
Exactly.
yeah.
Exactly. And so not only like we don't have to think about this just in the muscle, it happens as well in the brain. Okay. So
Yeah.
it's really good for perimenopause, menopause in terms of cognitive symptoms. So if you're having a lot of brain fog and you're like, you know what, let me just try something. Okay. Then this could be something that you could try on your own.
Yeah. If I've had a poor sleep, I do 10 to 15 grams of creatine, and it makes a huge
10 to
difference.
15.
Oh, yeah.
You know
Yeah.
what? I've seen studies that say you can do
Studies
that.
do
But
say.
yes, it's true.
Yeah.
You can do it.
It's true.
Yes, but I recommend for the regular girly, just like
N
a
equals
5.
1.
Yeah, there we go. N equals 1. I recommend like a 5 gram. That's usually the recommended amount. If you're somebody who weighs themselves every day, you might see a little increase, and that's just because it holds on to water more.
Yeah.
But I'm a big proponent of like, please don't weigh yourself. Please don't weigh yourself every day. And then focus on.
Okay, wait, I'm so curious about that because a lot of people say the opposite. And I actually find I go through periods where weighing myself every day is
helpful.
Yeah. Compared to not. And some people love that. But why do you think that?
Just like I'm coming at it from women who are in menopause, and they are just so at war with their bodies right now.
Yeah,
and
true.
Yeah, and they're finding, and like the scale can be so triggering. And I really, really, really want people to understand that like, I don't care. I don't care what you weigh. I do not care what you weigh. Okay. What's really important to me is like your body composition, is your daily activities, right? So like, are you active? Are you somebody who is like eating well? Are you somebody who's like, you know, in a healthy relationship? Like these are all markers of health for me that have zero things to do with your weight. Okay. And if I just focus on your weight and you're the kind of person who like eats at McDonald's every day and you don't exercise worth shit, well, you're not going to age the same way as somebody who I might have targeted, who like based on them being in a bigger body and pegged them as unhealthy, even though they are like CrossFitters, they are, you know, they're eating healthfully. They're just in a bigger body. So that is that's how I'm looking at it.
Okay.
If you're goal driven, you really want to lose weight, you're on a program, you're like, I don't want anyone to feel bad. You do you. Okay. But I'm saying in general, like people are like, oh, I keep gaining weight. I'm like, okay, let's get off the scale. Okay. And then let's look at some other things first. Okay. And so that'll be a conversation about like, okay, what treatments can we give? I also really like to address metabolism, like while we're at it.
100%.
But the first thing we have to fix is your vasomotor symptoms. The first thing we have to fix is your dry vagina. The first thing we have to fix is your lack of sleep. Okay. Because we can't do the rest of it without fixing those things first.
Why?
Because then you're not functional.
Yeah.
You're not functional. And so one of the biggest complaints, because we do know that lifestyle does play a positive effect in women. So stopping to smoke. We know that people's hot flashes can be triggered by smoking. I have to say in my practice, like usually women who advocate for themselves and who go out there and get it are not usually smokers. They're usually like the healthier, no offense, smoking ladies, love you. Okay.
Here she goes.
They're usually
not good. Then you know it.
Yeah. They're usually the ones who are exercising. Okay. They're the ones who have done everything. So once they get to their doctor and they're like, hey, like something is not going well. And they're like, have you tried exercising? They're like, yeah, I have. Okay. And it's not going well, or it's not alleviating their symptoms.
Yeah. And I think to add to that, for a lot of people, adding exercise to a body that's already extremely fatigued and depleted can make things worse. And you know, there is an analogy I heard recently that sort of, I like it. And I think depending on the person, it can be extremely helpful, but, you know, exercise adds, to your bucket, to your stress bucket, but it also pokes a hole at the bottom, right? To drain out. So, you know, if you are managing your volume well, if you're managing your fatigue well, and if your priority is recovery, then yeah, 100% exercise at the right time for the right person can be fantastic. But if you are so fatigued, so depleted, you're not recovering, you're not sleeping, you're not going to want to exercise, you're not going to want to cut and lose weight. And I think that especially for a society that's so focused, you know, like Ozempic right now too, and like so focused on image compared to how someone might actually be feeling on the inside, like that influencer that you're seeing that's super extremely lean, you have no idea what she's dealing with. You have no idea if her hair is falling out. You have no idea if she's like constantly obsessed with her body,
or
and
if
like,
she's doing the program that she's selling.
Yes. Yeah. Like there are so many health markers that come outside of the actual way you look, and maybe that you're not going to be your absolute leanest self when you're feeling your best. So it's always going to be a priority to get that sleep in check, make sure that your nutrition is in check. You're at least eating every day. Because there's so many women who like get to that point of menopause where it's like, I can't just like stop eating a little bit and lose weight the way I did when I was in my 20s.
Exactly.
But instead, they're really going to have to focus on eating more than they were, which is distressing when you notice that you're already gaining weight.
And so that's the thing. I'm like, please don't look at the scale. Like, please. And like, Okay, and while we're speaking of quotes that we saw, so Ashley had actually posted something. I think it was probably 2 years ago, but it really stayed with me. And I try to say this to my patients all the time. I'm like, if people saved muscle or the way they did, like save money for
Money.
retirement, okay, things would be totally different.
Yeah.
Okay, and so
Yeah.
we need to prioritize that as well as our financial health for retirement.
So
Because
true.
if you're ignoring your health for the entire length of time that you are like grinding, well then
Using your health credit card, it's like, oh, I can just bank on this
I
because
can
I'm still
bank on
young,
this.
whatever. And it's like,
No.
no,
There's going to come a
no.
time where you like cannot at all. And so
Yeah.
we do know. So postmenopausal women, they lose bone or they lose muscle at about 1 to 1.5% per year. So the good news is studies show that if you do work that and you do take, you do eat more protein. So this is something that is probably new. Women have like maybe been able to get away with like less protein prior. That's something that has to be changed. Okay, we do need to. It's slower to kind of like to build muscle, but so we need to really give it the
Yeah.
protein that it needs.
Yeah.
So 1 gram per kilo is, if someone's really keen, I don't usually give out that advice. Okay, I'll say please meet with a dietitian, but the guidelines or the recommendations are about 1 gram per kilo.
Kilo or 0.7
Yeah, and
per
just
gram of
follow.
pound.
Yeah, I'm like, oh, I don't know,
Per
but and then
gram per pound.
just
Yeah.
follow like the Mediterranean diet is amazing, not just for like for your entire like metabolism
Yeah.
in general.
Yeah. And I think what you said there earlier is fantastic in terms of like the metabolic health and the protein thing, because I think people are like, oh, I did never used to have to eat like this, but also the things that
You
we're
were never
dealing
in
with in
menopause.
modern times, also like the amount of chronic stress that people are dealing with, the amount of, endocrine disruptors they might be dealing with, and like the things that are sort of coming at our health from every which way, like our light environments, we're constantly scrolling, we're constantly looking at,
Oh my God, yes.
and like the amount of stressors that your body has to deal with requires an increased amount of protein. And it's not just about building muscle, it's about literally giving your body the ability to break down toxins, to digest, to fulfill bodily functions, to sleep, to create hormones, right?
Yeah,
So,
absolutely. Absolutely. And you had mentioned this just a little bit about Ozempic. I am not opposed to Ozempic as a
neither am
little
I.
metabolism fixer.
Yeah.
Depends on the gal. And I really think it's shitty that we have marketed Ozempic as a weight loss agent and that it has been so misused for that.
Yeah.
Because then we see people losing weight like extremely quickly. People who are not diabetic, who are on these diabetic doses, they're losing muscle, they're losing bone, they're losing all. And so I'm like, oh, if only we could like, and so what I'll do with my patients is I'll give them like quite a small dose and they're usually paying out of pocket too. So I'll be like, okay, like let's just take a more kind of like scaled down dose, see if that can just get the edge off because not often, most of the time, okay, in menopause, women also do become insulin resistant, okay? And so they're gaining weight. It's usually around the middle. They have that like late afternoon slump. Even if they are women who work out, they're still, because of a myriad of like biochemical processes.
Metabolic. Yeah.
Exactly. It does mess with your with insulin's like how it works, all right?
Yeah.
And so just to go over a little bit insulin resistance. So insulin is supposed to signal for the blood that's circulating or the sugar that's circulating in the blood to go inside the cell and feed the cell. Because there's like a faulty mechanism there that's not happening. So
It stays elevated in
it
the blood.
stays elevated in the blood, okay? And then it's stored as fat because the body's like, oh, well, it's had its chance to go by the cells and this is what's left over. So this is stored as fat. Whereas the cells are like, we're still hungry, okay? And so then it'll
And
send a
you keep
signal
eating.
that you're still hungry. So for
Yeah.
women will be like, I am a bottomless pit.
Yeah.
And so I'm like, okay, I think it's this. And so I'll order fasting blood work. So fasting insulin, fasting glucose. And I'm going to take a look at what your fasting blood sugars are and what that process looks like. And then, okay, do you have insulin resistance? Most likely. And then let's treat this too. But first, let's get the thing that brought you in here. Okay. So it's over a few months. Okay.
It takes time.
It
And it's
takes
like,
time.
and when you think about like the lifestyle factors that are associated with everything that contributes to insulin resistance, it's like you're talking about kind of an overhaul for a lot
Oh
of
my
people who have been
gosh.
living in chronic stress, scrolling all hours of the night, not sleeping, drinking, not moving after eating and just, eating and then sitting in front of the TV or whatnot, all of these things change your body's ability to metabolize glucose. And then suddenly sugar becomes the public enemy number one, and sugar's bad, but it's your brain's number one source of fuel. And it's also your ability to fuel your workout. So people are like, oh, I don't know what to eat. I'm confused. I'm insulin resistant. So like I react poorly to sugar, but then also sugar is good for me.
Yeah.
So it's like they're so confused.
Exercise will make you more like insulin sensitive, right?
Yes.
Because the
Muscle
more,
is
exactly,
extremely-
muscle is your best defense against
Yes.
insulin resistance.
Yeah.
However, for a number of genetic hormonal reasons, that might not happen. And sometimes you need an extra little push, and I'm happy to provide that little nudge. And if it's not a GLP-1, okay, like the Ozempic, the Mounjaro, then I'm prescribing like even a little bit of metformin, which is like a diabetic, which is like a pill, okay, that it's dirt cheap. I always call it like Ozempic's poor cousin. So on its own, it doesn't affect weight, okay? But if you're using it to reduce insulin resistance, because that is, based on your history, that's what's making you store this fat, okay, then that alone, like I've had patients who have lost trying, okay, it's only to be used as an adjunct with like an excellent diet and like weight training, and they have lost like weight because they're finally not feeling out of control around food. They're finally able to feel full.
It's so true. It's for a lot of people, it's like the emotional food noise to be like, oh my god, like I need to eat, and that also has to do with their satiety hormones, the signaling around like leptin, ghrelin, their hunger hormones, everything like that, right? Your body is going through a storm of confusion. And I think that also goes back to, go lifestyles, chronic stress, mindlessly eating.
Even like when we're kids, right? Like snack time's at 10. You're hungry, you're not hungry, like
You're gonna eat anyway.
You're gonna eat anyway.
Yeah.
Okay.
Yeah.
And so
not trusting your body's innate ability to regulate appetite and
well, you've been overriding
food
it since you were in kindergarten. So like, why would you stop now?
Yeah.
Why are we counting on people, or why are we telling people to stop eating when they're full?
No, exactly.
Some people have never felt fullness. Some people have never felt fullness.
Yeah.
And the GLP-1 is the first time. And so they're like, they come back, they're like, holy shit. Like, and so for that, I think it's a really cool adjunct to somebody who's already like living a pretty healthy life, and they just need a nudge. They need a nudge, and this is the nudge.
Yeah.
And
I think that also goes speaks to the fact that, I think there's a lot of shame around that stuff, and people are like, well, I just don't have enough self-control.
Oh
I'm
my
just not as
gosh.
disciplined as other people are. When it's completely unconscious, completely like, yes,
be genetic.
It is. I do believe that it is people's responsibility. You should have responsibility over your own health, and you need to be proactive and productive in advocating for your own health. And you do have the power to take control, but at the same time, there are so many factors, lifestyle factors, genetic factors,
And we see this in polycystic
habits.
ovarian syndrome, right?
Yes.
Because that insulin resistance is the basis for like 80% of those cases. And so some women will be able to regulate their period just by walking to work. Some other women are going to have to be like marathon runners. Okay.
Yeah.
That threshold is different in everybody. And so, yeah, you can quit your job and just train for Ironmans, but at what cost, right? So, yes, it is your responsibility to take control of your health. Okay.
Yeah.
But it's your responsibility to use the tools that are at your disposal.
Exactly.
Right.
Yeah.
And so, I get so mad when people are like, oh my God, she's so lazy. I'm like, no. I'm like,
The
do you know what
fatigue
this
that those
woman?
people-
Do you know what this woman is doing at home?
Yeah.
Okay, like this woman is doing the lion's share. Okay,
Yes.
there's nothing lazy about her.
Yeah.
It's
So true.
just
you have
like
no
kind of
idea
some
what people are going through at work
and just
and
like
at home.
some fat phobic like comments. And so I really try to stay away from that in medicine because it's been so common, and we were taught this way, right? Like obesity is bad. Obesity is bad. There's so bad habits that create insulin resistance are bad, okay? But somebody just based on their size does not necessarily have insulin resistance. They're not necessarily unhealthy. So really my message to doctors is like, just focus on this person's habit. Go the extra mile and be like, hey, do you exercise? Do you, how is your diet? Okay, great. Keep it up, you know? Instead of like, hey, you need to lose 20 pounds. I can lose 20 pounds. I'll just smoke a bunch of cigarettes and drink a bunch of coffee.
Exactly. It's an arbitrary goal.
And then am I going to be healthier?
No.
What's my metabolism going to look like? No, it's going to look like shit.
Yeah.
And so, and
No,
so
it's
what are
true.
we really talking about?
What's the mechanism? How are you achieving it? And I think that also just goes to like that images and everything. You have no idea how much people are starving themselves to get to, a certain level of skinniness online. And it's painful and it's hard work to do it the right way and to eat enough protein and to
And to be
exercise.
at peace with yourself.
Be
And
at
like
peace with yourself
gals,
and stop
we are
picking
not
yourself apart constantly.
exactly.
Yeah.
And gals, that is no small undertaking. Like
No.
I get that. Like, and yes. And so if you feel you do have that, I always encourage you, like talk to a psychologist who is specialized in body image, talk to a dietitian who's specialized in body image, because you want to approach these things from a health at every size. My personal
Your
thought.
mantra.
My mantra. Yeah.
Okay. I am so happy with everything we talked about. I think it's time for us to do your Kiss, Marry, Kill.
What? Okay.
Yeah.
Okay, let's do it.
Yeah? You feel ready?
Okay.
Okay. So, number 1, hormone replacement options: estrogen patches, oral progesterone, testosterone cream.
Kiss, marry, kill.
Yeah. Like, which one are you?
Okay.
Do you know what I mean? Like, which one are you marrying? Which one are you killing?
Okay.
Which one are you kissing? These all make no sense.
Okay. No, I'm going to kiss the oral progesterone.
The oral progesterone?
Yeah. As long as it's the brand, Prometrium. I'm going to marry estrogen patches and I'm going to kill testosterone cream. I will kill it.
Okay. So fair.
People think it will cure everything and it won't.
Okay.
It won't. That's a whole other podcast.
That is a whole other podcast. And for the people who know, you know.
And people who disagree, that's okay too.
That's okay too. Okay, bone health, calcium and vitamin D, resistance training, and bisphosphonates.
Bisphosphonates, okay. That's so hard. Okay, so
I get it if you want to say marry the vitamin D and the resistance training.
right?
I get
That's
it.
what I want to do.
That's fair.
That is what I want to do. I want to marry
accept
both
it.
of them. But I also still want to make out with biphosphonates because like listen, like if you need them, you need them, right? Like it's worth a shot. I mean, once you are diagnosed with osteopenia or osteoporosis, like the homework you would have had to do is 15 years ago, right? But biphosphonates can at least kind of stabilize. Like anyways, in my experience, it's kind of that.
Okay.
Kind of that. Okay.
Okay.
But if you could do both, that would be amazing.
Okay.
Okay.
All of the above. You mean?
All of the above.
Yeah.
Yeah.
Yeah. Okay. Controversial wellness trends.
Oh my God.
Seed cycling.
Oh my God.
Bioidentical hormones and soy fear mongering.
Huh? Okay, we can't eat soy?
Yeah.
Okay. Okay, no, I have heard that. Okay. So kiss, like, okay, wait, is it what I hate the most or what I like the most? What I agree with?
Whatever you hate the most and whatever you absolutely need to see gone from the zeitgeist, you kill.
Okay. I'm going to kill, okay, what was the last one?
Soy fear mongering.
Soy. No, I'm going to kill seed cycling.
Okay.
I'm going to kill it. Okay. And then I'm going to kiss soy fear mongering because like it's very low. Anyways, the risk is that there's too many phytoestrogens that it could be feminized. Like, anyways, like you'd have to drink a shit ton of like, like a shit ton of soybeans, like for it to do anything to like endocrinologically, but whatever, I digress. Okay. It's not most people. And then I want to marry what's left.
Bioidentical
hormones. Okay. Bioidentical hormones versus non-bioidentical. It really is just like a marketing thing, but like, I'm happy if it convinces people that this is like less dangerous.
The marketing works, then hell yeah.
The marketing works, and hell yeah.
Okay.
Some people cannot tolerate bioidentical, and then I don't want them to like limit themselves and be like, well, that's it for me. Like, no, there's so many options. We are like, and it's just getting better every year because like women, I don't know if you've heard, like we're now people, and like now they are like researching us.
We are people.
We are people now.
True.
It is cute. Anyway, and so
studies do show
that
we are people.
We are in fact people, and that we are making these big market demands.
Yes.
And these companies are answering.
Yes. Okay. Vaginal health edition. Vaginal estrogen, pelvic floor physio, and hyaluronic acid moisturizers.
Okay. So I need to marry vaginal estrogen. Okay. Everyone will need a vaginal estrogen at some point. If I could even like push it further, vaginal prostrone is new to the market the last couple of years. Okay. This is DHEA that like when it's put in the vagina, it will be transformed by the vaginal cells into either estrogen or testosterone.
Right, because DHEA helps to regulate downstream hormones. Yeah. Okay.
Exactly. Okay. And so it's doing that in the vagina. It is the only one. Okay. Everything is 100% safe, even in women who have had breast cancer, but there will be that black box warning on it that says this is an estrogen, like if you have cancer, blah, blah, blah.
Right.
Anyways, so I want that to be a very important caveat. Okay. The systemic absorption of vaginal estrogen is like undetectable.
Right.
Okay. Undetectable. However, okay, officially prostrone is the only thing that you could give to women who have active breast cancer.
Okay.
Okay. But then again, if they're already on something and you're on it, don't be worried. Okay. I want to make out with pelvic floor physio. That's an unbelievable tool.
So powerful.
We are so lucky. Did you know we have the most number of pelvic floor physios per capita in Ottawa?
Really?
Yeah. And my co-host on my podcast, Clearly Obsessed, Lisa Flanders. Yeah. Plug. She is like, she really started it all. Like she really like laid the foundation for that landscape in Ottawa. So I'd love it.
Yeah.
And I have so many patients whose lives have changed. Like either if it's like,
it's life changing.
Yes.
And people don't realize.
Even chronic back pain that's actually coming from your pelvic floor.
Pelvis. Yeah.
Pelvis. And then what do I want to kill?
Hyaluronic acid.
Hyaluronic acid. It's not doing anything. Like if your atrophy is, if your symptoms are caused by vulvar atrophy, there's only one way to treat that. And that's by replenishing estrogen. The hyaluronic acid is really just the ultimate Band-Aid.
True.
Liquid Band-Aid.
Yeah. And I mean, I guess if it gives people temporary relief, then sure, whatever. But it's not going to have the same effects as vaginal estrogen and pelvic floor physio. Especially as like a more of a systemic thing, like especially for the pelvic floor physio.
You know what I'm thinking? Like if you realize like, wow, I probably have vulvovaginal atrophy, but I won't see my doctor till 2 weeks from now. Let me buy some Replens, like perfect.
And sure.
Cool.
Yeah.
But it has to be just a temporizing measure.
Okay. Supplements for patients, like menopausal patients, magnesium glycinate, DIM, which we talked about briefly before, and black cohosh.
Oh, okay. So DIM, I don't even know what that is. Maybe it's an abbreviation for something. Black cohosh, we don't have enough like information about it. And then what was the first?
Magnesium glycinate.
Oh, I love magnesium glycinate or biglycinate. Like so great for recovery, for helping you sleep, just for anyway. So take it at night. If you take too much of it, you will notice your stools will be loose.
Sorry, with too much magnesium.
Yeah, too much magnesium because it is a smooth muscle relaxer.
Yeah.
So that includes the colon. And so, I just want to marry only that. I'm going to leave those other.
So fair.
I'm going to leave them at the altar.
At the altar. You're done. Okay. I guess these all suck, but I guess you have to choose which one's the worst of the worst.
Okay.
Estrogen causes cancer. Weight gain is inevitable. And you should just tough it out.
Oh my God. Okay. So definitely kill. You should just tough it out. No, you definitely shouldn't tough it out. Okay, you should do whatever increases your quality of life. We're here for a good time, not a long time. Yeah. So And so what was the estrogen causes cancer? No, if you've already had like an estrogen dependent cancer, I wouldn't give you more. But we do know in large studies. So for 2,000 women using menopausal hormonal therapy for 5 years each, there's an extra 5 to 6 breast cancer cases, but no increased mortality. So, so a lot of people are like, that doesn't even sound like anything to me.
Right.
And also like I'm suffering so bad, like I don't care.
Right. So for a lot of people, the trade-off is worth it.
The trade-off is absolutely worth it.
Okay.
And then what's the middle one?
Weight gain is inevitable.
Weight gain is inevitable. Oh, okay. So the studies show, that weight gain happens with time. Okay. Like it's, so if somebody takes a birth control versus doesn't take a birth control in those same groups, like people are just gaining weight.
Yeah.
Okay.
Yeah. Which I think probably has more to do with the muscle loss and the general metabolic changes.
Just as you age. Right. And so it's just aging. Okay. And then, yes, exactly. So general metabolic changes. I don't think weight gain is is something that will affect everybody, but a huge part, right? Or at least just feeling outside of their body, feeling not themselves,
Yeah.
or things not working the way they used to. Alcohol metabolism is a huge one, okay, which I know, like, you know, that's a toxin, like we should get rid of it. But for a lot of people, it's like, okay, I can't even really participate in like the family dinners, the like, you know, I can't have more than one glass of wine or else my sleep is perturbed forever.
Yeah.
So a lot of things feel like they are, how do we say? It's not inevitable, but the odds certainly are more stacked against you. Okay.
Yeah.
So don't be afraid to use the tools that become available, and don't feel like you're a failure if you haven't been able to do this on your own, quote unquote.
Okay. Diagnostics for our last one.
Okay.
FSH testing, Dutch testing, and blood hormone panels.
Gross. All of them gross.
All of them.
All of them gross. I don't
Kill 'em
care. I kill them all. Kill them all. The only time I would do that is if somebody doesn't have a uterus, and like then I will do an LH. Hormone panel, again, just a snapshot. Dutch testing,
The blood work,
so
you mean?
much
Yeah.
money for,
And the Dutch test.
yeah, for no reason. Hormone testing for polycystic ovarian syndrome, amazing. Okay, but like menopause, no. I can get, like, based on your age, based on your history, I can get a really good idea of what's going on and a really good idea of how to treat you. That has nothing to do with, you know, you having to do any extensive kinds of testing.
Hell yeah.
Yeah.
Okay.
Yeah.
You know, I love it. I love that you are defying the kiss, marry, kill rules and just killing everyone.
I just
Leaving everyone at the altar.
Yeah, I
You
love
all
it.
suck.
I love it. You can't make me marry anyone.
Oh, okay. This was actually the best. And I feel like you are just a wealth of information.
I feel like you know so much. I'm like, were you in medical school? Like you,
No.
yeah.
Thank you.
Oh my God, when you hit me with
read.
that DHEA, I was like, huh? I was like, good work.
I read a lot. No, I'm so happy you came, and I would actually love to have you again. I feel like we need to.
Oh my God, it was a
need to talk more.
pleasure, and I would love to.
An honor and a pledge.
It was an honor and a pleasure.
Okay, everyone, check out Rebecca's podcast, Clitorally Obsessed. And you can find her at Novel Health and
Lifespan MD, and L'Estée Collégiale.
There you go. You heard it here first. Thank you so much for coming on.
Thank you so much.
Oh,
Thank you.
Of course. Thank you guys so much for watching, listening, whatever. See you guys soon. Bye.